Good afternoon, everyone, and welcome to our second 2017 CPTHN webinar series. My name is Leo, and we are using a program called GoToWebinar. This session is being recorded, and you will be able to see it again on the CPTHN website. Before we begin, I'd like to go over a few housekeeping details to assist in everyone's participation. As always, at the end of the session, we will have a Q&A time going by region or by identifier, a person that has logged in on the computer. During the session, you're more than welcome to send your questions or to raise your hand, and at the end of the session, I will call you by name. A quick message to the Sick Kids team in the clinic conference room is that during the Q&A session, we kindly ask you to come up to the white microphone in the podium so that your question can be heard clearly. If you require any assistance during the webinar or encounter a problem, please enter your comment in the question box and we will try to address it. Alternatively, please feel free to call me directly at 416-813-7654 extension 205401. Now, with no further ado, please allow me to introduce our speaker who really does not need for me to do so. Dr. Mark Crowder received his MD from University of Western Ontario, where he also undertook internal medicine training followed by hematology training at McMaster University. Dr. Crowder undertook a focused research fellowship in thromboembolism under the direction of Drs. Ginsberg, Weitz, and Hirsch. He is the current chair and professor in the Department of Pathology and Molecular Medicine and a professor in the Department of Medicine. He also holds the positions of chair of the Research Advisory Committee for Heart and Stroke Foundation of Ontario and president of the Anticoagulation Forum organization. Dr. Crowder's clinical activities focus on the care of patients with thromboembolic disorders, management of complications of treatments for thromboembolic disorders, and other hematologic conditions. His research interests include a wide variety of projects, going from optimal methods to prevent and treat both arterial and venous events. He holds the Career Investigator Award for the Heart and Stroke Foundation of Canada and the Leo Pharma Chair in Thromboembolism Research at McMaster University. So today we'll have the pleasure of having Mark talking to us about the reversal of direct oral anticoagulants, a state-of-the-art lecture. Mark, I'd like to, on behalf of CPTHN, welcome you and thank you for taking the time to share your expertise with us. The floor is yours. Thank you.
Thanks, Leo, and thanks for the opportunity to do this presentation. It's a real honor. Hopefully, you can all hear me clearly. I'm going to present for 50 minutes exactly, and then I have to leave at 5 to the next hour. So I'm going to talk today about anticoagulant reversal with a focus on the direct oral anticoagulants. I'm going to cover a little bit on warfarin, and as I was saying to Leo when we were just chatting before the start of this, some people in the audience might wonder why this is relevant to pediatrics because of the current non-use of direct oral anticoagulants and limited use of warfarin in pediatric patients. But there's a lot of research going on, and people in the audience, some of you may be involved in this research for the various companies looking at the use of direct oral anticoagulants in children. And as time passes, I think as we found in the adult community, you'll find the direct oral anticoagulants to be a major advance in the care of these patients. And as a result of that, once we have evidence to support their use, I think you'll find that the direct oral anticoagulants are used with increasing frequency in pediatric patients at the doses that are determined by the ongoing research projects. So just moving to my next slide, which appears to be frozen. Just 1 second. See if I can get it back. Give me 1 second here while I fix this problem. That's interesting. I'm going to terminate my PowerPoint and restart it. We did try this out yesterday and it worked fine, so it just had a little near-death experience there because it was live. So I have, hopefully you can see those slides, I have disclosures. The major disclosure relevant to this presentation is that I've done consulting with Portola, the manufacturer of Andexanet, and I have done work with a variety of different companies that make direct oral anticoagulants and reversal agents, and some of the slides I'm going to present today have material in them that's produced by the manufacturers, and also some of the slides have had input from my colleagues, and I would like to thank them at the start of this. So the background to any talk on reversal is that we don't have level 1A evidence for reversal strategies for direct oral anticoagulants. There never will be large clinically driven randomized controlled trials to support the use of a reversal strategy, simply because experience has taught us that such studies are really quite infeasible. They're principally infeasible for a couple of reasons. The first is in patients with major bleeding, it's very difficult to enroll a patient who's critically ill with a life-threatening bleed into a study. These things inevitably occur on Friday at 11:35 p.m., so you have to have incredibly aggressive research staffing. But most importantly is the fact that the patients, particularly with the direct oral anticoagulants, are very uncommon, and as a result of that, you have to, the amount of infrastructure required to do the studies is truly massive. So we won't have good quality evidence based on large randomized controlled trials for most of our interventions, and in fact, the studies that have been used to have one reversal agent, idarucizumab, approved as a cohort study, and the study involving the Portola's reversal agent is currently also a cohort study. We're going to start out just talking briefly about warfarin, which I know is of limited interest to the audience, but it's a good illustration of some of the problems with reversal. So the bottom line on reversing warfarin is that despite two highly effective reversal agents, we really do a terrible job of reversing warfarin, and honestly it shouldn't be rocket science. We know how to reverse warfarin. If you look at the recommendations from the National Advisory Committee on Blood and Blood Products from Canada, they make a recommendation that to reverse warfarin you should use vitamin K and a prothrombin complex concentrate, and the American College of Chest Physicians in their 2012 recommendations also recommended the use of PCC. And yet we see on this graph and highlighted in the boxes, this is data from the RELY study, which is quite old. I've recently seen some data, contemporaneous Canadian data, and it's very similar to this. So these are patients in the RELY study, which was the licensing study for dabigatran in atrial fibrillation. Patients, it's an open label study, so the patients and the clinicians were aware of the intervention being used, and when a patient presented with major bleeding, there were 421 patients on the warfarin arm of the study who presented with major bleeding. Of those patients, you can see in the intersecting boxes that they received a median of 4 units of FFP, and yet only 5 patients, or 1.2%, received a prothrombin complex concentrate. And perhaps even more surprising is the observation that only 27% of patients received vitamin K. So the two specific reversal agents for warfarin-associated major bleeding were used in only a tiny fraction of patients in this study, and even if you include fresh frozen plasma, you can see that only 30% of patients received FFP. So only about half of patients received some kind of coagulation factor concentrate in the setting of a major warfarin-associated bleed. PCCs have a lot of advantages over FFP in the reversal of warfarin-associated coagulopathy, and we'll later talk about them in the context of direct oral anticoagulants. Everybody on the call is going to know that a PCC is a 4-factor or a 3-factor product that contains factors 2, 7, 9, and 10, with the 3 factors containing reduced amounts of factor 7. They instantaneously and selectively restore the coagulation factors that are reduced by vitamin K antagonists. They're manufactured to minimize viral contamination. They have a lower volume and shorter infusion time than plasma. They don't require ABO group specification, and from a transfusion medicine perspective, they're vastly more rapid to prepare than fresh frozen plasma. So they should be the agent of choice, and in Canada, if you're going to reverse warfarin, you should be using a prothrombin complex concentrate, not an FFP. This is data taken from Ravi Saroti's paper, which was a randomized control trial, which led to approval of this product in the United States. PCC in Canada, the drug, there's two, one produced by Octapharma and one produced by CSL Behring. In the United States, confusingly, Baraplex is called Kcentra. These graphs just demonstrate the levels of factors 2, 7, 9, and 10, comparing Baraplex and plasma, and you can see the big advantage is that within seconds of administering the prothrombin complex concentrate, you get near complete and instantaneous restoration of the important coagulation factors 2, 9, and 10 compared to plasma, which only slowly and in most cases incompletely replaces the coagulation factor. So if a patient presents with major or life-threatening bleeding and you want to correct their coagulation, the effective way to do that with warfarin is to give them a prothrombin complex concentrate. This drug has been available in Europe for many decades. There's a net exposure of in excess of 500,000 patients, and there's been no unexpected safety concerns identified since the product was first approved in Europe in 1996. And in PCC, not only is easier to administer, but it has the added advantage of reduced cardiac events, reduced transfusion-associated cardiac overload syndromes, and fewer allergic reactions than is seen with plasma. So there's many advantages to use of PCC. This is a case of ours from a number of years ago, just to illustrate the point. This is a patient who presented with an INR, you can see, of 9. The INR is the y-axis. And they received a total of 7 units of FFP, which reduced their INR from 9 to just over 2. They received an additional 2 units of FFP, which reduced their INR down to about 1.7, and then they finally got 1,000 units of PCC, which instantaneously dropped their INR. This was in the setting of a life-threatening bleed, and you can see that if someone had given them the appropriate dose of the prothrombin complex at the start, they would have had a vertical drop in their INR, and their INR would not have been a concern with respect to their bleeding complication. We've recently published a systematic review, Chatri, who's my PhD student, looking at all of the randomized controlled trial and observational data with PCCs. This was published just last year in Thrombosis and Hemostasis, and for the first time ever, you can see that this is a forest plot from our analysis which shows a survival advantage to the use of PCC, an odds ratio for death of 0.56 with statistically significant confidence intervals. So when you combine the data across all of the PCC and plasma comparative studies, patients who got PCC actually had a higher likelihood of survival. From a blood conservation perspective, PCCs offer a number of advantages. One is exposure to a manufactured blood product. It's more effective and rapid reversal and has a reduced likelihood of death. And it is also a more effective use of nursing and laboratory time. Move on to the direct oral anticoagulants. So in Canada right now we have rivaroxaban and apixaban approved. We have edoxaban, which is moving to an approval status in Canada. And there are a number of other products which are currently in investigations or have been submitted to licensing authorities outside of Canada. I think when we're talking about bleeding, some of you will have seen this slide before, it's really important to remember that these drugs, the direct oral anticoagulants, warfarin, enoxaparin, or the aspirins or platelet inhibitors, none of them actually cause bleeding because they don't contain elastase. They can't make holes in blood vessels. What they do is they make bleeding easier to see. They're like contrast agents. So this is the apocryphal story of direct oral anticoagulant associated bleeding. The story is that the truck driver is driving down Highway 401, which is the big highway that goes through the center of Toronto, and he swerves to avoid an obstacle on the road. He's got his rivaroxaban or apixaban or dabigatran pill bottle sitting on the dashboard of his truck. As the truck tips over, the lid flies off the drug bottle, and the dabigatran capsule or a rivaroxaban capsule or an apixaban capsule comes flying out and transects his carotid artery. That is DOAC-associated bleeding. Anything else is bleeding that the DOAC makes easier to see. And so my the reason why this is important is that the reversal strategy for any bleeding event, irrespective of anticoagulants, is fundamentally based on identifying the source of the bleeding and correcting it. Unless fired from a cannon, anticoagulants don't cause bleeding, and no amount of reversal agent of any sort is going to fix a blood vessel with a large hole in it. An interventionalist is required to treat most major bleeding events. And another apocryphal but true story is when I was asked to see a patient in our emergency department who had a CT scan which showed contrast in the aorta moving directly into the duodenum. The person had an aortoduodenal fistula, and the question that they had for me was, how do we reverse this person? And no, nothing that I do is going to improve that person's outcome. That person needs to go to a cardiac surgeon and have that problem fixed. So the key to managing bleeding is to identify and take out the source while minimizing blood loss, requiring a close collaboration with interventionalists, and reversal strategies are really ancillary to fixing the bleeding lesion. Another thing to remember when you're dealing with the direct oral anticoagulants is this is another paper published by Chatri which looked at the relative risk of adverse clinical events in patients treated with DOACs compared to patients treated with warfarin. Across the 102,000 patients enrolled in the studies which led to approval of the direct oral anticoagulants. And you can see that when you compare direct oral anticoagulants with warfarin, there's a statistically significant reduction in major bleeding, fatal bleeding, intracranial bleeding, clinically relevant non-major bleeding, and total bleeding without any significant difference in GI bleeding. And so even when we don't have effective antidotes for the direct oral anticoagulants and we have 2 effective antidotes for warfarin, you're still less likely to die of bleeding, about 50% less likely to die of bleeding if you're treated with a DOAC than with warfarin. So one of the important conclusions from this area of research is that when I have a patient who's got a high risk of bleeding and you ask people what they should be treated with, people will say, well, they should be treated with warfarin because we can reverse it. And in fact, the evidence that's available, this summary and others, suggests that in fact that's wrong. If you really want to minimize the person's risk of death, you should treat them with a direct oral anticoagulant because the risk of fatal bleeding is dramatically reduced with a direct oral anticoagulant compared to with warfarin. So the conclusions from this analysis performed by Chatri was that despite the availability of 2 specific antidotes for warfarin, you'll still rather have a bleed with a DOAC even in the absence of an antidote. And so the question then becomes, do we need a reversal agent for these things? And the answer is, of course we do. We need it for 2 reasons. One is a small number of patients will directly benefit from the availability of a reversal agent, and the second is that a large number of patients will indirectly benefit because their physicians and other healthcare providers will be reassured that the bleeding risk is not excessive with these agents and thus will use them, resulting in reduced morbidity in that patient population. So if you're faced with a patient who's on a direct oral anticoagulant or any other drug and they are bleeding, the first question you need to ask yourself is, if our goal is to determine if we need to reverse this patient, is the drug present in significant quantities? And so, you can't. There's no need to further consider reversal if a person does not have the drug present. So, one of my colleagues emailed me or texted me over the weekend to say they had a patient in the emergency department who was on dabigatran, who presented with a suspected intracranial hemorrhage, and they were asking how they should access the idarucizumab that we'll talk about later. I said, well, the first step of that is to do a thrombin clotting time, and if you do a thrombin time in a patient on dabigatran and it's normal, you can assume that the drug is not present in significant quantities, and thus you don't even need to begin to entertain thoughts of using a reversal agent. I'm not going to talk about drug measurement in any depth. I'll point you to this paper which was just published in the last couple of weeks by Bethany Samuelson, who's from the University of Washington, where she looked at the laboratory assessment of anticoagulant activity of the direct oral anticoagulants. And so what this is looking at the utility of commonly available lab tests like the INR, the PTT, the thrombin time, to discern the presence of direct oral anticoagulants. This is a little bit older paper that Dr. Siegel and I published a couple of years ago, and I'm not going to go through this in any depth. I just wanted to point out that there are a couple of resources that you can spend some time on to look to see how you can use commonly available tests, the INR, the PTT, and the thrombin clotting time, to determine if there are significant amounts of the drug present. And so you can spend some time reading this, but the summary is exactly here. So the picture is an epidural hemorrhage, and that's of course what we want to avoid and the worst possible outcome of anticoagulant-associated bleeding. The only test that we have which is effective at ruling in or ruling out the presence of clinically important quantities of these drugs is the thrombin time, and that's only useful in a patient on dabigatran. So if your question is, does this person on dabigatran have clinically important amounts of drug present, and you do a thrombin time and it's normal, you can conclude that they do not have clinically important amounts of dabigatran present. Many hospital people tell me that they can't do a thrombin time in their hospital, and of course that's completely untrue. Any hospital that can do an INR and a PTT can do a thrombin time. It's an easy to do test from a reagent perspective. If you can't get one, it's because your lab director has chosen not to offer it, not because you can't do it. Any coagulometer that can do an INR and PTT can do a thrombin time. In addition to the dabigatran thrombin time, what else do we know about common testing? Well, we know that a normal INR in most machine reagent combination probably rules out therapeutic but not trough levels of rivaroxaban. We know that a normal PTT probably rules out therapeutic but not trough levels of dabigatran. We know that apixaban does not have a reliable impact on the INR PTT and thus can't be ruled in or ruled out using these tests, and that the best test to determine if these drugs are present is a calibrated assay, which can be, in the case of the 10A inhibitors, based on simple 10A inhibition using known concentrations of calibrators, and in the case of dabigatran is based on a dilute thrombin time technology known as the hemoclot assay. So the first question is the drug present in significant quantities? And sometimes you can tell that from lab testing, sometimes you just have to go on the history. The second question then is, does the agent need to be reversed if it's present in significant quantities? And the answer to that question really depends on the nature of the presentation of the patient. So if the bleeding is minor, like epistaxis, or in most cases of menorrhagia, or if it can be easily addressed with interventions, again like epistaxis where packing may work, or if it's a need for surgical intervention but the surgery can be delayed, then waiting for these drugs to move out of the system is preferred to trying to reverse them. Remember that these drugs, particularly rivaroxaban and apixaban and edoxaban, have very short half-lives and are pretty independent of renal function. And so they're going to be cleared from the body pretty doggone quickly in most patients. Dabigatran is a bit different because it is renally dependent. Even this conservative strategy can be used for many even more serious bleeds. Many patients presenting with suspected lower GI bleeds are managed simply with attentive monitoring rather than some kind of intervention, because most of those patients aren't going to undergo endoscopy till the next day anyway. However, if the patient needs an intervention, if the patient presents with an imminent need for surgery, then it should go ahead and the interventionalist needs to be aware of the increased risk of bleeding. If you make a decision to reverse, then the next question is, how are you going to do that? And people say, oh, we can't because we don't have specific reversal agents for the 10A inhibitors. In fact, you can. This is a paper taken from a figure taken from a paper that Ted Workington and I published 2008, but we've republished it several times since then as more data has become available. You adhere to the principles of bleeding management, stabilization, intensive care monitoring, transfusion as required, work with interventional radiology, GI, or surgery. Consider non-specific procoagulant agents like DDAVP or tranexamic acid or Amicar. PCCs and APCCs I'll provide you with some evidence for later may be considered in patients with life-threatening bleeding. For life-threatening bleeding with dabigatran, you can consider the use of vidarucizumab, and for the 10A inhibitors, specific reversal agents are in development. A couple of caveats. The first is there's no role for FFP. FFP has no role of any sort in DOAC-associated bleeding. I'm amazed at the number of times that I get patients signed over to me by the emergency department who came in with a bleed and they were given 2 units of FFP. There's no role for the routine use of any blood product other than those required to correct a measured deficit, for example, packed red blood cells in the setting of identified anemia. And consider the use of PCC or an activated PCC only in the case of truly life-threatening bleeding in an otherwise salvageable patient. In terms of the evidence for PCCs, this is the best paper which has been published. It's a very highly contrived experiment. In this paper, which is very interesting, the authors exposed healthy volunteers to a single dose of edoxaban and then did these very aggressive skin punch biopsies in them that required scissors to complete the biopsy, and then they monitored them for the amount of blood that was shed with or without the use of a prothrombin complex concentrate. This is the graph from the paper which was published in Circulation. It's a phase 1 single-center, double-blind, randomized, placebo-controlled, two-way crossover. Enrolled 110 patients who received prothrombin complex concentrate at a dose of 50 units per kilo, 25 units per kilo, or 10 units per kilo following the administration of 60 milligrams of edoxaban. On the graph here, you can see on the x-axis the dose of PCC, on the y-axis the bleeding volume, and the darker gray is the placebo treated volunteers, the lighter gray is the 4-factor PCC treated individuals. If you look at the extreme right, you can see that in the 10 unit per kilo group, both the darker and lighter bars are above the 100, which is the 100% bleeding in the control patients. 25 units per kilo, similarly bleeding above the boundary. With the 50 units per kilo, you can see the dark bar, the placebo-treated patients had bleeding in excess of the boundary, but the light bar, the patients treated with the PCC, had bleeding below the bar. This is the best evidence that we have available that these agents may be effective for the treatment of bleeding, a highly contrived model. Joanne Van Ryn, who some of you will know, was the lead development scientist on the idarucizumab product and has published a whole series of very important investigations in this domain. This is a paper that they published looking at the use of activated prothrombin complex concentrate in patients, in pigs. This is the best available evidence that we have to support the use of APCCs. What they did in this model is they took these pigs, they lacerated their liver, they fractured their femur, and then they looked to see how much bleeding occurred when the pigs were exposed to differing doses of activated prothrombin complex concentrate. And the bottom line is that if you use doses of placebo of 25 units per kilo, all of the pigs bled, and if you use 50 units per kilo, all of the pigs survived. Again, suggesting that 50 units per kilo of an activated prothrombin complex concentrate like FEBA was effective at ameliorating fatal bleeding in this highly contrived model. So that's all the evidence that we have really that the PCCs work. There's lots of other papers looking at various models, but those are the two best quality ones. Let's move on now to tailored reversal agents. So the first is idarucizumab, which is a product which is manufactured by Boehringer Ingelheim. It's licensed and approved in Canada, and it's a specific reversal agent for dabigatran. It goes by the very useful name of Praxbind. It was approved by the Food and Drug Administration in October of 2015 and by Health Canada in April of 2016. The evidence available to support the use of prothrombin complex, of idarucizumab comes from a prospective cohort study for which an interim analysis was published in the New England Journal last year by Charlie Pollock. What this paper did is it took a total of 90 patients presenting to emergency departments and elsewhere who were felt to require urgent reversal of dabigatran. The patients were in two groups, 51 patients with uncontrolled bleeding and 39 patients requiring emergency surgery. You can see that the patients with major bleeding, a third of them had intracranial bleeding, a third had gastrointestinal, and the rest were a scattering of different things. The reason for surgeries are on the right-hand side of this slide, and there's lots of them, and they're all acute, very seriously ill people. I won't go through all the results of this paper. This really just highlights them. On the y-axis, we have the dilute thrombin time, which is a marker of dabigatran levels. On the x-axis, we have time after the idarucizumab is administered. You can see that at baseline, the dilute thrombin time is high, indicating the presence of drug, and you give the 2.5 gram boluses of idarucizumab in quick succession through rapid IV infusion, and you get instantaneous and complete reversal of the dabigatran effect, which lasts out till between 12 and 24 hours, where a couple of patients then suffer a recrudescence of the anticoagulant effect. But based on this, I think we can conclude with high certainty that idarucizumab is highly effective at instantaneously correcting the anticoagulant effect of dabigatran. When you reverse people, you're exposing them to a risk of thromboembolism. This is inevitable. Thromboembolism is going to occur because these patients are all on anticoagulants because they have a procoagulant state, and it's both logical and expected that you will see patients with thromboembolism. In the reverse AD study, the idarucizumab study, there were 5 thrombotic events over 90 days of follow-up. one of which was early, a deep vein thrombosis and pulmonary embolism 2 days after the idarucizumab was given, and 4 events were between day 7 and day 26 after idarucizumab administration. One of the big issues that we've identified in the andexanet study population is failure to reinstitute anticoagulation. Most patients who have a major bleed can safely have their anticoagulants reinstituted. Only a small fraction do, and the patients who fail to have reinstitution go on to develop thrombotic complications, which are probably avoidable if they had been appropriately treated. Let's talk for a couple of minutes now about andexanet for reversal of both the direct and indirect anti-10A inhibitors. Again, many of you have seen this slide, but andexanet alpha is a chemically or recombinantly produced modified factor 10A. Two important things happen in the manufacturing process. The first is, in order to produce an agent that's able to act as a decoy for the 10A inhibitors, the manufacturer changes one of the amino acids to eliminate the catalytic activity and prevent prothrombin cleavage, so that 10A becomes neutered, but it's still able to bind to, with high affinity, the factor 10A inhibitor. They also remove the GLA domain, the phospholipid binding domain, so that the andexanet alpha cannot participate in surface-based coagulation complexes, and thus it can't interfere with anticoagulation or procoagulant effects. The product has no known interaction with other coagulation factors except tissue factor pathway inhibitor, and it retains high affinity for antithrombin inhibitor complexes. And as a result of that, not only does it reverse the direct-acting 10A inhibitors like apixaban or rivaroxaban or edoxaban, but it's also effective at reversing indirect inhibitors like low molecular heparin, fondaparinux, and even surprisingly unfractionated heparin. I won't go through this stuff in great detail. Deb Siegel, who works with us here at McMaster, published this paper in the New England Journal just over a year ago, and we had a second paper published recently, which I'll present the results of. I'll just go through these boxes in a little bit of detail. So in the top left, we have a graph looking at apixaban, where patients were exposed to a bolus of andexanet and no infusion. And so what you can see is these patients are dosed to steady state. At that point, they have an anti-factor 10A activity of around 200 nanograms per ml, indicating good quality anticoagulation. When you give them placebo, the black-filled circles, you just get a slow decline in the anti-10A activity, as you'd expect. And when you give them the andexanet as a bolus, you get a rapid and near complete correction of the anticoagulant effect, which remains corrected over a period of approximately 2 hours, and then there's a rise and a return in the activity, reflecting a very short half-life for the andexanet. In the bottom left of the four, you can see what happens when you give given a bolus followed by an infusion. You get a sustained reduction in the anticoagulant effect for the duration of the infusion, followed again by a rise back towards the expected levels as time passes. On the right-hand side, we see very similar graphs for rivaroxaban with just a bolus at the top, or a bolus plus an infusion at the end. And the doses of the reversal agent required to reverse these drugs are interesting and different. For apixaban, it's 400 milligrams as a bolus, followed by 4 milligrams per minute for 2 hours. And for rivaroxaban, it's 800 milligrams, followed by 8 milligrams per minute for 2 hours. Last summer, we were fortunate to have a second paper published looking at the clinical utility of andexanet alpha. This is the results of our ongoing multi-center open-label single-group study, prospective cohort. In this paper, we were able to report the results on 67 patients who presented with acute major bleeding. At this point, there's no surgical cohort in the study, and these patients all had to have been believed to have taken their 10A inhibitor within 18 hours of their presentation. We evaluate patients for changes in anti-factor 10A levels after administration of andexanet, as well as their clinical outcomes. And of the 67 patients, we were able to evaluate 47 patients who had significant amounts of 10A inhibitor present. For the analysis, we felt it was unfair to present bleeding results in patients who had minimal or no drug present. And about a third of patients who we believe should have drug present are found not to have drug present. That's a consistent observation. In those patients with levels above 75 nanograms per ml, we found the mean anti-factor 10A activity decreased by about 90% for both drugs, and that we used a subjective measure of a clinical hemostasis, which was adjudicated as good or excellent in fully 3/4 of the patients who received the andexanet. There were 12 thrombotic events in 67 patients during the follow-up, and of these 12, only one patient had had a restart of anticoagulation, and in that case it was only prophylactic anticoagulation prior to their thrombotic event. So the summary for andexanet, and moving towards the end of the presentation, is that it's a specific short half-life agent that binds to and inactivates a variety of 10A inhibiting anticoagulants. It's administered either as a bolus or a bolus plus an infusion, and it does not change the underlying PK of the anticoagulants. Thus, because it has a short half-life, anticoagulant effect can be expected to recur, which is different from dabigatran, where in fact that does not occur. So I'm just going to talk for a couple of minutes about other drugs. Sirparantag is another novel inhibitor of anticoagulants, which is under clinical development. Jack Ansel is leading the development of this, and this is a paper that was published in Thrombosis Research just very recently. In order to use Sirparantag in assays, you have to use an assay known as the whole blood clotting time, which is an older clotting test, which we don't use very often. There's a chemical issue with the Sirparantag. For this graph, what patients did is they received a dose of enoxaparin, and then when they were felt to be at peak, they received a dose of Sirparantag. And you can see they received 100, 200, or 300 milligrams. With the black dashed line, you can see what happens when you give placebo in terms of the change in the whole blood clotting time over 28 hours. And with the red, green, and blue lines, you can see what happens when you give Sirparantag. Essentially, a rapid, dose-dependent, and near-complete elimination of the enoxaparin effect is observed. Sirparantag has a couple of advantages over the other drugs. It's a low molecular weight and appears to work for multiple different anticoagulants. It has a major disadvantage, and that is that it's further behind in its development algorithm, and so we don't really expect it to be available for some time if it ever does achieve approval. So in summary, and leaving lots of time for questions, warfarin reversal for surgery or bleeding should be easy, but it's not. In 2017, dabigatran reversal should be easy, and the reason it should be easy is we have idarucizumab, so for patients with major life-threatening bleeding, idarucizumab is required. The reversal of the 10A inhibitors remains problematic. There is some soft evidence for the use of PCCs, but nothing very hard. It's really important to remember, though, that a properly administered reversal strategy, which is not just a drug product, it's also the strategy that goes around that, using the right product at the right time and the right dose, will reduce bleeding and all the complications of bleeding. That's the entire presentation. I'd like to thank you for your attention, and we've got about 15 minutes for questions, so I'd be happy to entertain any questions that you might have.
Thank you very much, Mark. Perhaps let me see if I can go by region again, favoring the mics that are opening. Let me start with going out west. Let's see if Mary Bowman from Edmonton. Mary, do you have, your mic is open. If you have a mic in front of you, do you have any questions for us? It doesn't look like Mary has a question or a mic in front of her. Let me go to another speaker, Dr. Israels, Manitoba. I don't know if Dr. Israels has any questions for us. I'll remind everybody that you can type your questions in the absence of a note from Dr. Israels. Let me see if if Jason Stoffman. Jason, do you have any questions for us?
No, nothing for me, thanks. Good talk, though.
Thanks, Jason. Dr. Gallagher, do you have any questions for us? No questions. I'll move on down the list. Dr. Runa Singh. Runa, do you have any questions for us, or a mic in front of you?
No questions right now, thank you.
Thank you, Runa. Let me start getting closer to Ontario. Let's see if we have speakers. Maybe I can open the floor to see kids reminding you to please come to the white microphone to pose your question. I'm opening the white microphone. Any questions from the floor here in Toronto?
We have one question. Oh no, we have to touch here.
Please go ahead.
I can hear you.
Hi there. A question from Toronto. Most of these drugs that you're talking about are all in tablet form. Are there any studies to look at drug dosing for pediatric patients and how they're going to remedy that in liquid form?
So the the short answer to that question is I didn't really touch on this at all, but for the direct oral anticoagulants, all of the drugs have very advanced pediatric programs dosing down to very small children and infants. I happen to chair the DSMB for the BEAR program, and there's other people I'm sure on the call who are involved in others, and certainly both the way the drug looks, I mean, is it a tablet, is it a suspension, is being actively studied. Also, you know, as you guys all know better than I do, kids like to make this really complicated, and so not only is the suspension different or the tablet different, but also the doses that are required are very different in young children compared to others. So I think from a direct oral anticoagulant perspective, for sure there's going to be different ways of delivering these drugs. In terms of the reversal agents, they're all parenteral doses. I would have, you know, if Leo were to call me and say they've got a 12-year-old who is being treated with dabigatran for some reason, which is obviously wildly off-label and shouldn't be done, who presented with major bleeding, and what dose of idarucizumab to use, I would have no idea. But I would say that, you know, we do see 42 kilogram, predominantly women presenting on dabigatran, and we have some idea how to manage them. So, you know, in general, I think given the fact that the particular idarucizumab doesn't appear to have any dose-limiting toxicity, if you're considering using that for a bleed even in a smaller infant, smaller child, you'd probably be looking at the usual doses. It does have this handy 2.5 gram vial, of which there's 2, so I suppose for a very small person you might dose reduce. Obviously that's totally off-label, there's no approval, and if anybody from Boehringer Ingelheim is listening, they've just fallen over dead, because we shouldn't be talking about it. But I'm sure that if you went across Canada, there are now people who would be considered in the pediatric age group getting direct oral anticoagulants because they're so easy to use compared to warfarin or enoxaparin. Hopefully that answers your question.
Thank you very much, Mark. As a matter of fact, meanwhile, we receive 2 questions from the audience, one coming from Dr. Gallagher. Is there any data, or are you familiarized with any data of reversal of DOACs in children that you could share at this point?
Yeah, there may be people on the call who know about this, but I've not heard of anything at all. Again, predominantly because the use of the DOACs are all extremely off-label. That having been said, you know, I think we all have the experience that there are 15-year-olds who are 6 foot 2 inches tall and weigh 110 kilos, and to me those look like adults. So I'm sure there have been cases of people at the upper end of the pediatric spectrum who've been on these drugs and who have presented with bleeding. I'm just not familiar with them. If anybody has clinical experience with them, it certainly would be worthwhile writing that up, because you would get the first publication in the area, and it's always best to be first.
Yes, and the next 2 questions are coming from Dr. Israels. What type of laboratory screen do you think should be available in peripheral hospitals? And is it possible to have specific assays in tertiary care hospitals but for patients that are on these agents in rural sites as well?
So great question, thank you. So again, for dabigatran, it's easy because the thrombin time can be done on any coagulometer, ACL, STA, Sysmex, whatever you have. You just have to get it set up. So dabigatran is straightforward. If your question is the drug present in significant quantities, yes or no, you can do a thrombin time, and if the thrombin time is normal, you can be certain there aren't significant amounts present. For the 10A inhibitors, it's going to be a lot more complicated. You know, I think at 2 a.m. in Brandon, Manitoba, if your INR is 1.9 and you're on rivaroxaban and you have no other reason to have an INR of 1.9, you can conclude with confidence that that INR elevation is due to rivaroxaban. Apixaban, you can't really tell. We have many advantages in Canada compared to our colleagues in the U.S. One of which is political stability. The second of which is that we actually have approved assays for the 10A inhibitors, and so you can buy commercial assays for rivaroxaban and apixaban. Our coagulation lab has them set up. Some places across the country do. I was recently in Edmonton, and in Edmonton they've taken a slightly different tact, and that is they have set up a 10A, essentially a screen for 10A inhibitors using a different assay system. And whatever you've got, your hospital lab can set it up, and it would be a useful thing. In adulthood, we do not do rivaroxaban, apixaban, or dabigatran levels very frequently, so they tend to be fairly expensive tests to maintain. They aren't expensive to run. And so in a pediatric center, I doubt you'd ever have cause to set them up, but certainly in Winnipeg, there probably should be at least one lab that runs them. In Calgary, there should be one. In Edmonton, there should be one. In Saskatoon and Regina, there probably should be one. And so I think each of the major centers across the country should have access to a 10A level. More probably because, for example, a patient comes in and is going to require surgery, and the question is, do they have significant amounts of the drug present, and that you can help to answer that question. Acute bleeding is an acute emergency, and it's unlikely you're going to be able to turn the tests around in a reasonable length of time.
Excellent. Mark, I was puzzled. Thanks for your answer. I was puzzled by the data that you've shown that despite formal recommendations for reversal of Coumadin overdosing by the usage of vitamin K and or plasma, and less than 20-something% would have followed those recommendations. You're closer probably than anybody else to the information of specific reversal agents in DOACs. Now, what the literature you've shown and the complexity of lab availability made me immediately think maybe you're already aware of data, or how really feasible do you think will be that these agents will be utilized, given that a much simpler alternative, i.e. plasma and vitamin K, are used in less than a third of patients? What's the future you envision for these agents?
That's a wonderful question, Leo, and it's tough because your antidotes exist for two reasons. Again, there's going to be a small fraction of people. So let's say you have a 17-year-old girl who fractures her leg skiing. She has an open reduction internal fixation. She comes back to the hospital 2 weeks later with a big deep vein thrombosis and a pulmonary embolism. She gets treated with apixaban or rivaroxaban at the appropriate doses. On the day 3 after starting apixaban, 2 hours after taking her apixaban or rivaroxaban, she presents with a massive upper GI bleed. That patient, if andexanet's available, should get andexanet. If they're dying or going to be very ill from that, it would be, in my opinion, malpractice if you have access to that drug not to use it. Those patients are going to be super rare. They're just not going to come in that often, but you've got to have the drug and you've got to use it for them. The bigger group of patients is, as I mentioned, the fact that having antidotes will provide reassurance to clinicians that these drugs are safe and effective to use. I am amazed at the number of times when I ask people why they haven't used rivaroxaban or have used warfarin over rivaroxaban. That the reason they tell me is that there's no reversal agent for rivaroxaban. Despite the fact they know that rivaroxaban or apixaban is safer than warfarin, they continue to use warfarin because there are 2 reversal agents. And so I think having the reversal agents, just having a vial of them in your hospital, is going to increase the number of patients who are getting these highly effective drugs to treat venous and arterial thromboembolism.
Sorry, thank you, Mark. And I know that the floor has one more question, but before we do that, let's quickly go to Quebec to ask Dr. Davy. Michel, comment ça va? Vous avez quelques questions? Maybe no questions from Quebec. And there is a final from Dr. Simoneau, Dr. Jennifer Simoneau. Jennifer, do you have any questions for us? Nothing there. We'll go back to... Oh, pardon?
I said it's Christine. We don't have any questions. Thanks. That was a great presentation.
Thank you. then we'll finalize. Mark, I know you have to leave shortly. Opening the floor again to CKIDS. Please come to the mic and ask your final question.
Leo, thanks. Mark, it's Bill Bryan. So just one quick question, not on the antidote. What's your feeling? You really like rivaroxaban, and I agree with you. What's your feeling when the Ontario government will only pay for 6 months of it after the age of 65 on the ODB program, and then they say go back to warfarin? How do you get around that?
So that's a great question, Bill, and it's complicated. So the first thing I don't do is I don't fudge LU codes. There are people say, oh, just use the atrial fibrillation LU code. No one's ever going to look. I don't do that. I work in Hamilton where, in general, we can reduce things to a pretty simple level. So for apixaban, after 6 months, you can go down to the 2.5 BID. That costs the same amount as about 10 non-native cigarettes, or about 25 native cigarettes, or 2 cups of coffee. And everybody in Hamilton that I know of can understand those 2 currencies. And it's very rare for patients to honestly not be able to afford those things. There are undoubtedly patients who can afford them, but the vast majority of patients can actually afford to pay for it. I've not had to go, I've treated an awful lot of patients with these drugs, and I'm not sure that I've ever had anybody who really honestly couldn't afford it. I've not had to approach the companies to see if they'd be willing to support people. I suspect they probably wouldn't be. You can put in a Section 16 request, I suppose. I'm not sure that would be very successful. So, Bill, it is a tough question for that fraction of patients who can't afford them. But the first thing is that, these drugs are pretty inexpensive, and so most people can afford them. It is, in my opinion, unfortunate that at 6 months, if you can't afford it, you have to go back to warfarin, which is really, I think, in my opinion, a poor second choice. But it is effective, and we do have a lot of experience with it. And at least as long as labs continue to have coagulometers and do INR testing, it is a viable alternative to the new agents at 6 months if you're forced to go back there.
Okay. Thanks, Mark.
Yeah, thanks, Bill.
Thank you, Mark, and thanks for all participants. We will close the seminar by reminding everybody that on April 18th, we'll come back to McMaster when Dr. Shannon Bates will present to us a webinar on contraception and thrombosis in adolescents. Mark, always a pleasure. Thank you very much for participating, and we're closing the session.
Great. Thanks very much, everybody.